to the chat with your name and organization. That will allow us to make this time purposeful. And if you have any comments, questions, or concerns that are like uppermost in your mind and are part of the reason why you are joining me in the wee hours of the morning of being awake and worrying, I would invite you to go ahead and just send that expression, that question, that concern into the chat log. This is when I was a teenager. George Clinton in Parliament, Funkadelic, said just lay it on the radio and let the vibes flow through. If you put it in the chat, it will allow us to know what we need to work towards. And this is where the brother said, funk not only moves, it can remove. And our aim here is to try and see if we can not only move and advance those things that we most assuredly share and believe in, but it's also to see if we can remove some of that angst and concern. My team knows that I am a big believer in the simple fact that wherever I lack facts, I tend to fill the void with fear and with fancy. And so I ask them to make sure I have facts so that I can bid farewell to fear and fancy. And so that is our ultimate aim. We won't accomplish it today because there are too many questions, but if we can begin to chip away at the gap of knowledge so that we can operate on a shared foundation, I think we will be able to say when this call is over with that it was not just another call where a good time was had by all and or we checked the box that we were present, but rather it will be one of those conversations that really helped us move more closely towards achieving the beloved community that keeps us all engaged together. I am going to say it is 5 minutes after the hour, and we are going to call ourselves into order. And I would thank you before all other things for being here. And I'll confess that even after 2 years, this Zoom thing does still remain a strange format for me. As you all know, I'm usually doing an event like this after having worked the room for 15 to 30 minutes, hugging everybody I could, laughing, and just being in your presence. And then I would have been yelled at by the organizing team of today's session to stop talking and come to the stage. But I would have done what is the most important thing for me. And I thank you for letting me do it in these 5 minutes of virtual time with you. And that is sharing love with dear, dear friends. So again, thank you for being here. Please know that each of you have rain checks for my hugs, and each of you have my best wishes for your continued safety, health, and happiness until we can gather together again. I am incredibly excited by our being here today, and I am excited by the power and potential of the state's draft application for SHRPA, Strategic Health Equity Reform Payment Arrangements, to address in the context of the systemic barriers to care, the inequities in our community that have been highlighted and exacerbated by the COVID pandemic. And I'm really excited that all of you have joined us so that we can continue the community conversations that we've been having since the state advanced the framework for this application last August. I'm going to come back to this thought at the conclusion of our time together. And I know that we will reach that point of conclusion sooner if I stop talking now. So let me move to a quick agenda review. What we're doing right now is listening to Wade drone on with welcoming and opening remarks. And after a few items of housekeeping, I will yield the talking stick to Carol Tagus of the Flips, who will continue the excellent work she's been doing since August of level setting by sharing with us an overview of the state's draft application for Sherpa, the Medicaid waiver, and helping us understand the evolution of the state's policy proposal as it has evolved since the August conceptual framework was released. And I would be remiss if I did not thank Carol and the incredible group of partners that have been working hard in the background to help us be prepared for this moment, to have engaged in the coordinated effort of ensuring that our region responds to this draft proposal in a manner that is influential in how the state amends this application to evolve and support the incredible and necessary work, best practice work that is taking place in our region that can be strengthened and sustained through this waiver opportunity. From among that group of partners, after Carol's overview, she and I will be joined by Jamie Saunders, President and CEO at United Way of Greater Rochester and the Finger Lakes, and by Laura Gustin, Director of Monroe County Systems Integration Project. As a group of four, our shared aim will be to, in the spirit of distributive leadership, have a family conversation that can help inform all of our collective organizational and individual responses to the draft waiver proposal and to the waiver process. And friends, since in the world of Zoom land, housekeeping is no longer about me pointing out where the bathrooms are or where the coffee is located, let me use housekeeping to ask that if you haven't done so, that you sign into the chat with your name and organization. As I said earlier, that will help us with note taking, and that you feel free to start loading the chat with questions that you have or with feedback that you'd like to offer. This content in the chat will help us prepare for the open forum. And let me publicly acknowledge and thank Common Ground's COO, Albert Blankley, who is taking on the role of chat moderator, and he will be the facilitator of curating and responding to your chat input and or directing it to the panel for response. And your input and our conversation today will help us amend and more widely disseminate what we've been calling the Finger Lakes Region's 1115 waiver FAQ document. It is a list of what are those frequently asked questions and the answers to those questions that we partners have been curating and keeping. We launched it as a result of the conversation that we've been having with Dr. April Aycock of the Monroe County Office of Mental Health, CCSI's Ann Wilder, and all of the regional county offices for mental health and community services in the region. So that will conclude my opening remarks, and I will eagerly await your help in evolving that document, and we will share it with you as a parting gift on the back end of our time together. Carol, I'll yield the talking stick your way, my friend.
Great, thanks, Wade, and thank you all for joining us today and taking some of your Friday to hear about the waiver. It's not easy stuff to listen to, so I'm going to apologize in advance, and I'm going to ask you to bear with me. There are two paths here, and I chose the latter. One path was very, very high level overview where you leave frustrated because I didn't really explain much, or a little bit of a deeper dive so that you have more content that you can think about. As Wade said, we are recording this, and I believe Albert is going to get the slides out to those of you in the chat who put your email address in. This was not a registration Zoom. We wanted to keep it as broad of an open invite as possible. So be sure to put your email in here so we can keep track of who wants a copy of the slide deck. I also want to provide a caveat that this slide deck is only as of 4/29/22, and it is a compilation of my understanding of the waiver, as well as a compilation of various consultants who have jumped on the opportunity to analyze the waiver and summarize the waiver. So if you see something different than you have seen, or if you hear about something different, or if you see any other updates, or if you have connections at New York State where you're hearing something different, please, please, please let us know so that we can update this document. Okay, and I have to say, as Adam Bellows said the other night at the Vaccine Task Force celebration, I hate following Wade Norwood, but here I am. Luckily, Wade is going to end after I speak, and you will probably forget how dry this part of the presentation was. So, okay, let's go ahead and thank you, Albert, for keeping up with me or keeping me on track. So if I see you switching slides, that's my signal that I'm taking too long. Okay, Albert. All right, so let's start with a definition of this 1115 waiver. I do not mean to offend anybody and presume that you don't know what it is, but just in case, we want to keep this slide deck as comprehensive as possible. So the section 1115 comes from the Social Security Act, and it's really just a way for the federal government to allow for Medicaid funds to be used differently than is required under federal rules, and it's specifically related to the Medicaid program. Little PTSD picture there around the DSRIP kind of logo, Delivery System Reform Incentive Payment Program, DSRIP. Yes, I do remember what that acronym stands for, that we administered as the Finger Lakes Performing Provider System, ran through from 2015 to 2020, and that was an 1115 waiver demonstration project. As we go through this presentation, you will see that this is not DSRIP. It is very different than DSRIP, and I believe refreshingly different than DSRIP. And we'll talk a little bit about that when we kind of talk about lessons learned from DSRIP. Okay, next. So just to kind of go back in time a little bit, the concept paper. This came out in August 2021. New York State published this, and this actually was submitted by New York State to CMS back in August. The request was for $17 billion for the waiver over 5 years. And after reviewing this and after a little bit of angst in our community trying to understand that concept paper, which was 32 pages long, many of you have heard Wade and I present on it and iterate on that presentation as we learned more. That 32-page document was reviewed by CMS, and CMS liked what they saw, and they invited New York State to submit a formal proposal. And so if you feel or hear some of the things repeated that you have heard me present before, it is because the waiver proposal that has come out now is based on the concept paper. There are many more details, but a lot more detail that is left to be desired. So you're going to see a lot of the same themes. You're going to see a lot of repeated slides here, but we wanted to make this as complete as possible. Okay, so now we're going to get into some of the meat here. So fast forward to a few weeks ago, April 13th. So New York State published the waiver proposal, and the key word is proposal. This is not the actual waiver. The actual waiver is what the federal government ultimately approves in negotiations, after negotiations with New York State. So right now, this is the proposal that New York State has drafted. This proposal has not gone to CMS. You may have heard me say and Wade say that we had thought that New York State would simultaneously send this proposal to the federal government, to CMS, while at the same time as publishing it for all of us to comment on. They did not do it that way. They actually published it for us to comment on, but they shortened the comment period down to 30 days. So 30 days, and Wade is going to talk about the timeline of all this at the towards the end of the presentation here. So again, this is not the waiver. So every time though you hear me say the word waiver or hear anybody in the community say 1115 waiver or waiver, we're talking about the proposal that is pictured here. That's about 56, 57 pages. And I think there's a link. Yeah, there's a link. And maybe Albert, if you have a minute, you might want to put it in the chat. I know it was in the email as well. Okay, so again, this waiver proposal builds on the concept paper. It has more details on the themes and concepts. And this is what New York State, once New York State finalizes this document based on the feedback from across the state, they will submit that to CMS, at which point CMS and New York State will start to negotiate. There'll be kind of like this dark period. As Wade noted, New York State is seeking public comment and written feedback. And we're going to talk about that at the end, what all the different forums are. And it was in the email that you may have seen. Okay, so the new name. So we have a new name. Wade described what it is, and we are calling this Sherpa because that's what the state is calling it because they couldn't help themselves and they had to create another new acronym. And the concept is still the same, integrating social care and healthcare into the fabric of the New York State Medicaid program. The original concept paper called for a $17 billion investment by CMS. This proposal scales that back to $13.5 billion over 5 years. I will point out that is still bigger than what the first waiver back in 2015 was, and that was $8 billion. So this is $13.5 billion, and waiver periods are 5 years. Again, these are incentive dollars, as I stated in previous presentations. This does not change how Medicaid is reimbursed right now. That is parallel to this process. The potential start date might be scary. They're looking at a 1/1/23 start date. Given our past experience with these kinds of things, it would mean likely that regional planning would happen in January. So that is yet to be determined. Okay. I always want to say, are there any questions? But I realize that Albert is monitoring the chat and I'm not hearing or seeing that. So I'll just keep going here. All right. I'm going to start with a quote because I've been around Wade for a long time now and he's rubbing off on me. I don't know if that's a good or bad thing. You can't connect the dots looking forward. You can only connect them looking backwards. Steve Jobs said that. And that's what we're doing here. Again, the focus is on the word demonstration. We want to promote innovation, learn what works, what we should be doing differently, and really push for continual improvement. So to provide a little bit of a frame of reference, we want to understand the lessons learned from DSRIP. We want to build on successes, learn from the things that didn't go well. So I just want to highlight just a few successes because I can't help myself after spending 7 years doing this work with all of you and earning a few gray hairs along the way. Although Wade, I'm noticing, is catching up with me. So here we are. But I am older than Wade, I think, by a few months. To provide a frame of reference, some of the successes that we had, and I'm not going to go on and on about it, but we did as a state achieved over a 25% reduction in avoidable hospitalization utilization. That was the big push that the state had, and that was a deliverable to CMS that the state achieved. We improved clinical outcomes across the region by using community-wide population health incentives. Any of you who were involved in the jog and the sprint, I know crazy names that we had towards the last couple of years of DSRIP, we pulled together as a community, we aligned on what clinical outcomes we were going to focus on, a dozen, less than a dozen, and we moved the needle on those things. And it proved that with alignment, with incentives, money, and with collaboration, it could be achieved. We increased the number of integrated offices related to primary care and behavioral health integration. Much more work to be done in that space. Actually, much more work to be done in all of these spaces. PCMH, patient-centered medical homes, increased substantially. All of the work that Juanita Lyde and Lenora Reed-Rose and CCSI helped us with on CCHL, cultural competency and health literacy, I believe created a foundation for a lot of the DEI work that's going on now. Really grateful for that. And to me, that was a great success. Again, a lot more work to do in that space. But most importantly to me, it was about developing partnerships and collaborations across the region. Now, no loss of challenges. Many challenges that many of you could easily put in the chat and make me sad about, but I want to be realistic. And here are just a couple of pieces. We knew that there was an enormous amount of difficulty engaging with the CBOs and providing meaningful connection to clinical outcome metrics, the ability to work with them on data and work on incentive models, et cetera. New York State restricted the amount of funds we were able to flow to CBOs. They had this quote unquote 95-5 rule related to safety net providers. I won't go into the dirty details of that. The PPS has pushed and pushed and pushed the state, but they would not because that was a federal requirement. Many reasons. It doesn't matter. All we know is that piece of the pie or that piece of the initiative didn't work as well as I think there was intent. Other lessons learned, we really needed to focus more on social determinants of health, on health equity. Managed care organizations did not have an opportunity to be meaningfully involved. And guess what? Managed care organizations is where the value-based payment and funding mechanisms are. So that was a big miss. And I think the state recognizes it, which means in this waiver, the managed care organizations are going to have an incredible role. Patient health equity and social determinants of health data needs to be collected. VBP contracting needs to incentivize providers, and let's learn and act on the lessons that we understand from the pandemic around health disparities that have always been there. Okay. Funding mechanisms are going to look different. Albert's moving me along. And here are some of the themes before we get into the mechanics of what the structures are going to look like. So overall, big push on health disparities and continuing to work on systemic healthcare issues, health equity, integration across healthcare, behavioral health, and social care. A lot of focus on community-based services and CBOs, and relief and fortitude for COVID-19 recovery, especially with the hospital systems. A lot of focus, especially moving from the concept paper to this waiver, a lot more focus on workforce. So the state did hear people really worrying about workforce, and so they beefed that up in the waiver. And all of this moves toward very aggressive advanced VBP models as a goal. Okay, hopefully I picked up some time from that slide. All right, so let's talk about the goals. So these have not really changed based on what we presented before. Goal 1, promoting health equity and social care. This is where I'm going to focus most of my attention today because this is where the most of the meat is. The second goal is around supportive housing, community-based settings, specific support for BH and SUD. Third goal is about health equity in workforce, really also pandemic response and ensuring that there's a well-trained and diverse workforce as well as retention for that workforce. And fourthly, a new fund called the Equitable Virtual Care Access Fund to fund innovation in healthcare technology and digital health. All right, so now we get into these slides that I know are hard to see. So I've got a couple of ideas here. This is the hero slide, as we call it, and this is New York State slide. So this is a copy paste right from the waiver proposal. Generally, this slide should look familiar based on what we've shown in the past. They have a few tweaks on it. I'm only flashing this so you can kind of connect the dots when you look at the waiver and you think about the past slides that we've shown. The next slide is the better slide. And I stole it from, I didn't steal it, I asked for permission. Josh Rubin from Health Management Associates did a presentation. He and his team did a presentation on Tuesday. I'm sure many of you participated in it. It was an excellent presentation. And there's a couple of slides that he has that are the kind of slides that you print and you keep in your portfolio as you're traveling and thinking about the waiver and talking to people. This is one of those slides. It's a nice, I know it's a lot of information here. It's a nice diagram that encapsulates everything you need to know about the HERO as it is proposed in the waiver. Okay, I highly recommend you download these slides. The next slide will show you the link, and we could probably put it in the chat as well. I did promise Josh that I would plug it because it is really a good piece of work here. All right, I'm going to start, let's see, I'm going to start at the top here. So under governance requirements, basically the HERO has to be a mission-based organization that is focused on regional coalition building and collaboration. In our case, and luckily for our region, Common Ground Health was called out in the waiver document in the concept paper, and again is called out in this waiver proposal. Next, we are talking about what that relationship would be. It would be by virtue of an operating agreement with bylaws, one HERO per region. I'm going to put a pin in the region discussion for a minute because there's some questions and controversy, and I'm a little concerned about the regions as they're defining them. That HERO would have agreements with what they call participant classes, but basically they're providers, managed care and other kind of supporting organizations. So anybody who's anybody needs to be under the HERO. Managed care organizations, community-based organizations, organized through what we're going to call SDHN, Social Determinant of Health Networks. I've got another slide similar to this that talks about the SDHN, behavioral health networks, hospitals, health systems, IDD, long-term care, qualified entities, the Health Information Exchange, the RIOs, community-based providers, including private practices, physician practices, and population health vehicles. In other words, the accountable care organizations, independent provider associations like AHP, GRIPA, FLIPA in our region, as well as the BHIPAs. Other stakeholders to kind of round it out. All right, so then moving to the left, we have what the funding and sustainability looks like for these entities, the HEROs. They will get funding for regional planning, and that is going to be based on the kind of scope of the region, based on the Medicaid population in that region. Existing Medicaid payments, as I said earlier, remain intact. So what, fee schedules and all those things that happen through Medicaid, that is not touched. The HERO is going to get a limited amount of money when we look at the funding kind of earmark schedule, which I'll show later. And that money is for planning purposes and all the work that the HERO has to do. The HERO will not be a funds flow organization. And the idea is that this HERO would extend beyond the life of the waiver and continue this kind of work. And theoretically, some of the participants could help sustain that organization moving forward to kind of bring all of these pieces together for kind of community-wide, region-wide population health to bring everybody up at the same time. Who can serve as this kind of an entity? Well, an LLC, a nonprofit, in our case, again, Common Ground Health, in other regions, PPSs that have remained intact. Out of the 25, there's about, I don't know, between 5 and 8 of my colleagues have sustained their organizations. In some regions, they will become a HERO. IPAs could, government units, FIP, obviously the Common Ground Health is a FIP, and other stakeholders. But in our region, because New York State called up Common Ground Health, we are presuming and hoping that Common Ground Health will be the HERO. Core activities over to the right in the middle, it's about planning, managing data sharing, integration of all the platforms, activities, and efforts, and really aligning everybody in the green boxes there towards the same goals of the waiver, kind of like an oversight body. The deliverables will be a regional plan, outcome measure selection, VBP intervention design with some guidance from New York State. And there's a big emphasis in this waiver, which I did not see in the concept paper, around the HERO being very involved in housing and working on an inventory for housing capacity. Up at the top, there's a map of the region that HMA put in there. I have that red box. That map has to be updated. We had questions to the state around the regions because the link did not match what the waiver document said, the link to the site. And so we've got a little bit more clarity. And if you look at the regions that are linked, I think they updated and fixed it. It doesn't make sense, frankly. It's Medicaid rate setting region, and it absolutely does not reflect the kind of care and the care patterns that we have in our region. So that is something that I personally and my fellow PPSs will be advocating for, that there's flexibility in defining what the region for the hero would be. Okay. Next, this is a resource. This is where I pulled a couple of these slides. My team members, I got a bunch of texts from partners who said this was a great presentation that Josh Rubin did. And I talked with him last night. He allowed me to take a couple of his slides. I just want to give him due credit. And there's the link. And I highly recommend you download the presentation and maybe even listen to the recording, because of course the words help put everything into context. Okay, next slide. All right, so here is the state's social determinant of health slide, which is, it's okay. Again, I'm going to use HMA slide, which is based on the hero slide, same kind of format, which I really think is nice to talk through. So Albert, you can move to the next slide. This is though a picture of what's in the waiver, but this is a nice descriptor of how it actually works. Okay, let's start up at the top here. So the SDHN would be a network of community-based organizations. The region would overlap with the region and subregions potentially. Back to the regions, there could be subregions, but in the way I see it, the regions that are defined right now are too limiting, and in our case, we would be expanding, not doing subregions. The lead entity over up in the left-hand corner here could be a large CBO. It could be a network of CBOs. It could be an IPA. It could be an accountable care organization. There are many options for what the SDHN, Social Determinant of Health Network lead entity, could be. I believe it's supposed to be one per region. Trying to get clarification on that a little bit more. Somebody could correct me if they actually read a specific thing in the document, but I might be kind of thinking about the concept paper, but more clarity to get on that for sure. All right, and then so basically you have examples of what kind of community-based organizations would be part of the SDHN. I believe this is not necessarily exhaustive, but it gives you an idea of the prioritized areas of the kind of CBOs that the state sees as being part of the SDHN. And then this will go through a procurement process for a statewide social needs IT platform. They're allocating $30 million to quote unquote select a statewide platform for social needs. I believe we have a lot of investment and activity in our region around systems integration project with My Wayfinder and 360 Collaborative Care Network with NYDOH. So this kind of changes the game a little bit if the state is going to go ahead and do that. So if you have feelings about that, and you'll see in our kind of community high-level comments, I think we do have feelings about that. And it would be good for the state to hear what we think about that and whether we think it's a good idea to have this statewide platform and or allow us to have flexibility to leverage local, regional initiatives and activities and investments that we've already made and perhaps feeding into something that is statewide. As far as deliverables, the SDHN would be responsible for organizing the CEOs or CBOs, managing and coordinating a referral network, being a single point of contact for SDH arrangements for VBP or fee schedule, and creating a uniform assessment tool, which is not different than the concept paper around social care issues and screening. And I know many, and that is core to a lot of the work that everybody does, core to the systems integration project, core to the NYDOH work that people are doing with 360. And it is really around connecting that social service provider network with the clinical provider networks. In other words, integrating social care with healthcare and vice versa. Again, the map at the top needs to be updated, and same discussion applies around what the region is. So this is where a lot of the work is going to happen. And a lot of the dollar funds flow is going to happen. And I'll talk about that in a second. Okay. All right, let's move on to the next slide. All right, I'm still on goal number 1, the little thing at the top. I do have those color coded so that you can kind of match back to the page with all the goals. So we're using navy blue for goal number 1. So lastly, on goal number 1, the waiver allocates $7 billion or 52% of the dollars for VBP. It's a substantial amount of money that's allocated to VBP for this waiver. So this slide talks about the new concepts around advanced VBP, or really how the 1115 waiver will support long-term sustainability and promote movement to VBP with the social determinants of health networks, with the clinical care networks. So going across the slide here. So the state wants to use VBP to address social care needs. That's that kind of goal. Arrangements will be managed and distributed by the managed care organizations. They're going to be using risk adjustments, attribution, which is basically how they're identifying patients where the funding mechanisms follow the patients, what the coding is to be able to capture the data around this, and other mechanisms to incentivize the providers who are doing this care. So VBP in the waiver amendment includes a mention of social care need fee schedules and or subcapitated payments that will be administered by the managed care organizations. Ultimately, the goal is to, at a more mature state, and SDHN could be potentially taking a subcapitated amount and design their own fee schedule arrangements where they take dollars as a group and then they flow funds down to their downstream providers, similar to, let's say, a health home now, where the health home entity is kind of like the layer that manages a lot of the work and flows funds to the care downstream providers, care management agencies, for example. That's kind of how HMA described it when they talked about this. So how will the funds flow work? Let's go to the next slide. I'm sure at this point you've got 1,000 questions. I don't even want to know what the chat looks like right now. So Albert, I hope you're keeping up. All right, so managed care organizations are going to partner with organized providers to participate in VBP. So this is what the funds flow looks like per the state. This again is a snip out of the waiver document. There's going to be VBP contract requirements. So the focus is on prepaid or global payment models. There's going to be an identification of target populations based on the need for the region. There'll be minimum data sharing requirements with specific quality and health equity measures that the HERO designs. Now, the good news in our region, Common Ground Health has brought together various organizations who are in this space to work on, in their metrics advisory committee, the beginnings of collecting race and ethnicity data in a much more meaningful way with the Rio, for example. We need providers to kind of really embrace that so we have meaningful data in order to be able to measure health equity, develop the health equity measures to begin with. So that's a big change. That's a big shift. You can't measure what you don't collect, I think is the phrase. And so there's a lot of work to be done in this space. I'm hoping that the state is going to give us guidance around those health equity measures, but also give us flexibility locally to address the needs that we have here. So the managed care organizations would also support with risk mitigation strategies, and there will be an emphasis on social determinant of health components. There is a lot more detail that is needed in this space right now. There's only so many pages in the waiver. This is pretty complex, and it will require pages and pages and pages of more explanation and detail. And that is what CMS in New York State will likely negotiate. And the ultimate waiver document will be pretty substantial, pretty thick. So because it's only 56 pages or whatever, it does give us an opportunity and gives you an opportunity to think about this, put your questions together, put your questions into the survey feedback and the chat today so that we can really narrow down what our community is thinking and what our community needs and what is our community thinking about this model. Okay, so the idea is, and this is a better picture of funds flow. This is another slide that I stole from Josh Rubin, and it gives you kind of an idea of funds flow, and it's kind of technical, but it is a better way to show how the funding might go. So from DOH to managed care organizations, there would be VBP dollars. VBP dollars would be negotiated through these provider agreements with lead VBP entities, such as the IPAs, ACOs. There would be VBP arrangements with VBP networks. And then there will be perhaps an opportunity for global payments that are a dollar amount that's assigned, fee schedule activity going on underneath day to day, and then reconciliations quarterly, let's say, truing things up to the global capitation or the global payment. So it's kind of a reconciliation model where you still be submitting claims, but yet there will be a reconciliation process. And this is a little bit more mature than I was expecting, frankly. This is a little bit of a jump quickly into VBP, a little bit more advanced than I would have expected in my kind of 30 years working in IPAs. But it does give us a little bit of a stepping stone where we start with identifying potential fee schedule models for social care needs. What does it cost to provide transportation? What does it cost to provide housing? What does it cost to navigate somebody to social care needs? Turn that cost into a fee, turn that fee into a fee schedule, and turn that fee schedule into a negotiated document with a payer under this demonstration pilot, and start to kind of practice what we're preaching. Pay for the work that we have all deemed as really critically important that the community-based organizations are providing to improve health equity, to improve clinical outcomes. Track that activity, report on that activity, identify what's working, what's not working. That's the whole point of a demonstration project. Now I'm getting very passionate about this, so I'm going to stop and let's go to the next slide. Okay, I wanted to give you an example because this is really lofty and kind of academic. So this is an example, and I took the liberty of actually doing some copy pasting off of Google. So the waiver document calls out the North Carolina Healthy Opportunities Pilot, which was a waiver. It was an 1115 waiver initiative. And what I did is I provided here some examples of social care benefits reimbursement under a waiver. So I literally copied, I mean, this thing is like pages and pages. And what I did is you can kind of tell I'm not really good with PowerPoint, but I snipped a couple of interesting points to show you kind of what I'm talking about as far as a fee schedule. Service, unit of service, rate or cap. So for example, under housing, there was a whole list. First one was housing navigation, support and sustaining services. In this particular case, they're going to pay per member per month, $400.26. Next one, violence intervention services, which I was really pleased to see in this waiver. Domestic violence is called out as a priority. This one, $168.94. The numbers don't mean anything, it's just the concept, okay? This is North Carolina. I have no idea. I'm not a community-based organization. You would know if that even makes sense. Adjusted for Finger Lakes region. Fruit and vegetable prescription, cost-based reimbursement up to a cap, up to $210 per month. I think I saw Mitch, or at least Julia, maybe one of you is on this call. I don't know what you think about that, but that's kind of what they're looking at. Healthy food box for pickup, one food box. You know, you can see kind of how they costed that out and what the fee schedule is. Reimbursement for transportation, reimbursement for health-related private transportation. So you get the idea, okay? And I have the source here if you're interested in kind of poking around at the North Carolina model. I'm just trying to make it a little bit more real for you. Okay, additional focus areas, goal number 1, and we're going to move on to goal number 2 in a minute. So a few other elements that really support achieving health equity goals, workforce training and development. Workforce is the kind of big topic, as we all know, and as we are feeling the pain from. There's a lot more investment in workforce investment organizations, which are statewide state designated organizations that focus on workforce development. I'm pleased to say that FLIPS is one. We really have an opportunity to leverage the learning management system that we built if we were able to participate in this waiver and really power up the workforce development in partnership with everyone for this community, for the healthcare and community-based workforce. Community-based workforce is specifically the focus, right? Those outside of the walls of traditional hospital setting, that's where they want the workforce dollars to be invested in. New career pathways and training is focus, health equity and diversity. And then there is a call out related to the criminal justice involved populations. I specifically am saying that is a term that the waiver uses. I have been told that that is not an acceptable term, and I just wanted to call that out. But I did want to reference what the waiver language is. They're looking at getting those released from jail connected to Medicaid a lot earlier, and then supporting them in their transitions back into the community. Okay. Next slide, goal number 2. And now it's going to go quicker from here. I promise. This is a New York State slide, and I'm keeping it. I think it's self-explanatory. Basically, waiver amendment goal number 2 is all about housing, really looking at investments for homeless, transitional, and long-term institutional populations. Looking for the hero to do a region-wide inventory of housing availability and capacity, really focusing on high utilizer pockets of the population and partnering very strongly with the COCs, which I'm really happy about because I did not see that. I don't think I saw that in the concept paper. Local housing authorities, local agencies, and providers, et cetera. They would then work with the managed care organizations and the VBP contractors being these ACOs, IPAs, create more funding into a housing pool. I think that there's going to be more funding for bricks and mortar around housing, and then feed and loop and integrate with the social determinant of health network for the services that they provide around medical respite, transition services, coordination of care, benefit coordination, all of that. Really important stuff. Okay. Next slide is goal number 3. We are talking about organizational stability and workforce shortages. This is really the pandemic goal. This is about unwinding the quality restoration pool and really providing some dollars for critical access hospitals, safety net hospitals, and nursing homes to really get to the quality improvement that they need, better prepare them for future pandemics in coordination with all the partners in the HERO. Workforce investments I already talked about, but I'm really glad to see a lot more focus on diversity and pathways and really achieving health equity goals and workforce equity goals. Actually, I should have put that in here. Okay, goal number 4, this purple. This is about Equitable Virtual Care Access Fund. I think I talked about this single fund that would likely be, I think it's going to be a grant process where organizations will be able to apply for funding related to telehealth modalities and other ways to increase patient care. This again is a state slide, gives you examples of what the state is looking to invest in. And I believe, I don't have it here, but the waiver actually has a breakdown of the dollars that they believe they want allocated to each of these little boxes. So you can check that out. Telehealth being extremely important in order to really recover from this pandemic, and frankly, to be more efficient as a healthcare, social care system that is integrated over the course of, the next few decades. And who knows what it's going to look like, after I'm gone. All right, this is kind of an interesting slide. This is the money. Now, if you recall, the first time I showed a slide like this, it was $17 billion. Again, this is $13.5 billion. And the first column is what the allocation is over the 5 years, 8.6 to goal 1, 1.5 to goal 2, $3 million for system design, pandemic stuff, and workforce, and $300 million to digital and telehealth. I put a percent of total on here so you can see kind of the split. I also added the original concept paper dollar amounts. And this is what HMA did also. This is not their slide, this is mine, but I thought it was a good idea. And I got feedback from some of my colleagues that it would be a good idea to show the pluses and minuses since the concept paper, because obviously between the concept paper and the proposal, there was a lot of feedback to New York State. And I believe that feedback is reflected in the changes. So you can see that workforce got a lot more money. Well, more money, right? From one to 1.5. And because it went from 17 billion to 13.5, they had to shave off from the other categories. But the HERO does get some more money because I think that the state and maybe potential HERO organizations said, hey, we're going to be doing a lot of work here, a lot of herding cats, a lot of coordinating, a lot of guiding, and we need a little bit more for infrastructure. Okay. So overall, they cut 20% off of the total. All right, go ahead. So I did steal this slide from HMA, and this is a great slide. This shows you how the money's split up or potentially going to be split up, or what their intent is, and it gets behind their thinking, VBP being the most important thing. Housing, safety net, pandemic, obviously, and workforce. Okay. All right, so I'm winding down to the end here. This is kind of where we start getting to Carol's opinion. We are very well positioned to achieve the waiver transformational goals with all of the initiatives that we've got going on in our history. We've got a lot of activity and commitment to achieving racial equity. So much more work to do, but I believe that we are all on the right path. Community engagement has definitely increased, especially with initiatives like Systems Integration Project with a human-centered design approach. All of the work done at all of the various tables and initiatives that we're just so well known for, really taking a community-based approach. We have a strong regional planning element with Common Ground Health. We have robust infrastructure that already exists in the form of Common Ground Health and the RIO and systems integration, and the 360 network and the BHCCs and FLIPS and county government and all of the transformation support structures and community tables, the children's organizations, Children's Institute, Children's Agenda, just a lot of good work being done in this community that has solid infrastructure. And we have proven how we can come together and work on this kind of a large scale initiative to make things better in our region. We have a proven track record of innovation. Again, still much more work, more to do. So what should we be doing? What should providers be doing? This is, again, just my opinion. Listen to as many consulting waiver webinars and just keep yourself informed. Everybody's going to have a different take. My take is figure out where you fit in. What are the things that you're doing now that map to the waiver? Read the waiver document. I know it, you got to do it over a cup of coffee on a Sunday morning or a glass of wine, whatever is your choice. I prefer the glass of wine, but definitely read it, highlight it. As Wade says, take your pencil, draw on the margin, circle, get mad, get glad, and, take notes. What are the services that you're providing that really map to the goals? Understand what's going on in this community around social determinants of health, who's doing what are the screening tools, what are these infrastructures building that help support you, how are they coming together, how do you fit into those structures? Know your neighbor. Really, what are the natural care patterns that are going on? What are the referral relationships you have now? How might those referral relationships be strengthened? What are the gaps? Is there food providers that you really haven't been able to connect with? Is that something you want to connect with? Is that something that will help your patient population and you're not doing it now? Is that something you're interested in doing? Although we do want to make sure that organizations don't do twists and turns and gymnastics to try to fit a square peg in a round hole, or whatever that analogy is, because you want to stay true to your own mission. But look hard at your organization and the great work that you do, and how that fits into the waiver and how you are contributing to the better outcomes of the population. How are you measuring that work? How are you collecting data? What kind of data are you collecting? How does that data get standardized so that it can be shared? How are you viewing that data? How are you analyzing it? How are you putting packages together that say, look at what our organization has done and look at the improvement that we have seen in our population, and then translate that into these VBP mechanisms, learn about VBP. You don't have to be an expert, just understand what your organization does that makes a population healthier. And then read the waiver, keep informed, provide feedback. There's going to be plenty of opportunities. It's a very short window. I'm going to end here with another favorite quote, who I don't know exactly who said it. Preparation creates opportunity. It's just one of my favorite things. Prepare, and then the opportunities will happen. But in doing so, remember, we have a short window here where we have an ability to tell the state what we think will work and not work in our region, and boast about the kind of great things that we're doing here and what they shouldn't do all over again, what they should do instead. And really, let's see this as an opportunity to make a big change, combine this with all of the other money that's coming into the community with behavioral health dollars and ARPA dollars and FQHC federal funds. And it's a moment in time that we may never, ever see again. So let's take that opportunity and go with it. So thank you so much for listening me go on, and you can have Wade back and you could wake up.
Carol, thank you so very much. And that was excellently done. And friends, I am so delighted at the rigorous conversation taking place in the chat. It is absolutely helpful towards achieving our shared end. So as stated, friends, I'd like to invite Jamie and Laura to join Carol and me on this virtual stage. And as they do so, figuring out how to unmute themselves, video on, and the like, I'll just say, as some of you know, I spent the Holy Week, that incredible window during which we experienced and celebrated the Passover, Easter, and Ramadan, all while experiencing a full moon. It's been such a unique and rare moment that I've been thinking and talking about liminal spaces, about those moments in which we find ourselves leaving one place and space in order to enter another. Like my foyer downstairs, it's important to have liminal spaces that provide the opportunity for us to get ready for changing and trading places. We need liminal spaces, friends. And that's what we're in right now. This is a moment of transition, a moment of leaving behind what was and claiming and creating what will be. And liminal spaces are best when they support what we call, in my faith tradition, getting ready for that great getting up day. And so this liminal space has been enlarged and is being furnished with this call today. And I am so very grateful for the fact that Jamie and Laura were available to join us. They are among the partners that are helping us. And so I invite Albert to start our sharing, knowing that Jamie, Laura, Carol, and I are on point. And if I defer to my colleagues, just consider it to be the kindness that I know that you all can only sustain so much of hearing Wade Norwood's voice at any one given time. Ladies, thank you for joining us. Albert, you are now the modulator of this conversation.
Thank you, Wade. And I'm going to take the slides down for a little bit while we engage here, just so that it's easier to see everybody. And do want to acknowledge that we're going to save some minutes at the end to talk through timeline and next steps, and close us out. But there are a few questions in the chat that I wanted to give some opportunity for folks to air. And the first one that was raised was a question about children and infant and maternal health. I want to thank Dr. Kazarowski for sharing the Children's Agenda's position on this, and know that everybody has the link to it, but maybe invite you, Dr. Kazarowski, if you just wanted to say a couple of thoughts in brief about how that's going, or your thoughts on it.
Sure, Albert. Thank you. And thank you, Wade and Carol. Thank you, Jamie and Laura. We at the Children's Agenda have been focused on Medicaid and reform for a long time. And I want to really acknowledge our community and FLIPS, because in the last waiver, we were the community that led around maternal child health. But at the same time, I have to say that statewide, hardly any of the regional entities that were focused on Medicaid reform had any focus on women or babies at all. Only 2 out of 25 of the regional entities had a focus on kids and families. And unfortunately, we're right back where we started in this current waiver, with little or no focus on kids, despite the fact that you all know that it's front page headlines of the New York Times, again this Sunday, that kids are facing a severe crisis in their mental health. A Children's Agenda poll in Monroe County showed that 5 out of 10 parents say their children's health is a crisis. Their children's mental health is a crisis. 50%, and higher in the city of Rochester. And the other thing that I just really want to point out is, in a waiver focused on equity, right? The E in that Sherpa is equity. Kids are the poorest and most diverse segment of our population. Proportionally, they are the #1 user of Medicaid in New York State. There are glaring disparities. Black women die at 5 times the rate of white women in New York State during pregnancy. 5 times. Black infants die at twice the rate of white infants in the first year of life. And the waiver does not address those particulars at all. So I know I'm preaching to the converted, Wade and Carol, Jamie and Laura too. Laura, thank you for your recently joining the board of the Children's Agenda. But I really think we need a response from our community focused on kids and families. And I think somehow we have to extend that so it's heard in other places to the state as well. Thank you, Albert, for the opportunity to talk. I welcome people's thoughts about this and the opportunity to influence the decision at the state level to include kids and maternal child health.
Thanks, Dr. K. So want to make sure we keep moving. The next question that I have is, what do we know about the process for procuring the lead SDHN entity? What will the role of the existing PPS, i.e. FLIPS, be in that process yet? Do we know?
I suppose that question's for me.
Please, Carol.
Yeah, not sure. I mean, right now, the way that they describe it, there are many opportunities for different kinds of organizations to be an SDHN. Like I said, IPAs, already existing networks. already, historically kind of, organizations that have been working together. So it remains to be seen. I think we have a lot of discussions in our community that need to be had about that and whether or not the state is requiring one SDHN, more than one. In our region in particular, we understand that what the kind of care patterns and the kind of needs that are in Monroe County are not necessarily the same as in the other regions, in the other counties. So there are many discussions that I believe we need to have in this community about SDHNs. There is a lot of good work that's going on right now in our community that fits the mold of what an SDHN would look like. And it could be a collective of all those things.
Carol, can I just follow up? I mean, I
Yes,
think
Laura, yeah.
the state just doesn't have answers. I want to just highlight there's a survey out right now. I hope you all take it and share with us your ideas of what it should be. Like, this is the opportunity to provide that input and to influence the state in this area. And as we pull together the responses, hopefully we can see some consensus across our region for what we want SDHNs to look like. And if so, it's an opportunity to have a collective approach in sharing that information with New York State.
Absolutely agree with Laura.
Thank you, both Carol and Laura, and we'll make sure that that link to the survey gets circulated along with everything else here. The next question that I have is, how long is the comment period open? I saw that someone did drop the response in the chat, but just so everybody knows, New York State's comment period for written feedback closes on May 13th. And there are details if you go to the waiver website to figure out exactly how to submit. You can submit either via email or in old school snail mail as well. Let's see. The next note that I just had was a comment, and I apologize because I wasn't able to catch who said everything in the chat. But VBP for social determinants of health is a pretty broad concept. I'm hopeful that specific measures are developed. I don't know if anybody wants to comment on that. I think that is our expectation, that specific measures will be developed, but I don't know if the panel has any comments.
I did drop the draft VBP roadmap that's under construction into the comments, along with a link, which is cited often. Again, I think this is a work in progress. And part of that will come directly out of the negotiation with CMS as well. There are things underway, and this waiver document proposal is not the end all of the conversation. I think really taking the time to look at the VBP, the new draft VBP roadmap is really important to really extend your learning on where the state's headed in the VBP space.
Thanks, Laura. Next was a comment on workforce, discussing making sure that we are supporting our staff's own healthcare needs and really achieving, in my parlance anyway, that fourth aim of the triple aim and succeeding in that joy of practice. Allowing employers to support costs of improved care benefits. And as an employer, we find we are a provider of supports to our staff. Is that a possibility? Do we think that that's a possibility?
I can jump in on that since we've been doing a lot of work in the workforce. One of the things that I always say is the social determinants of health are the same as the social determinants of education, the social determinants of employment, or the social determinants of everything. And so I think it'll be imperative that if we're going to do something different with workforce, that we have to design things and innovate on social care needs as it relates to workforce. So, depending on how much flexibility the state will give us, I'm committed to driving that. If we are, as a WEO selected to be part of, who's going to be leading the workforce. And I would suggest, if that's important to you, and I presume it's important to everybody, that we include that in our feedback.
Great. Next couple of questions are talking about community-based organizations, and maybe I'll try and combine them for the sake of doing this. But really, is there what do we expect the relationship with those community-based organizations to be in these VBP arrangements? Do we have any specifics yet on what that might look like, including upside and downside risk, at the risk of using terms that may not be familiar to everybody? What are our expectations? It seems like this is a significant part of the waiver. Do we have any knowledge about what that's going to look like at this point?
If I could, Albert, I'll start that, and then Carol, please chime in. So I just wanted to offer at United Way of Greater Rochester and the Finger Lakes, we want to hear from you as our CBOs. We are providing testimony. We're compiling written testimony. We want to encourage you to respond to the survey that Laura mentioned and Albert will put in the chat. This is such a critical moment, and as the presentation was happening, I was being texted in private message, and I know there's a lot of fear. I think Wade started us out with that. There's a lot of confusion. This is very much healthcare language, and making sure that we translate that, and we are committed to helping in that space. This feels scary, and it also is an incredible opportunity. We, as the community-based partner organizations, have been seen and valued, and we have to make sure that that comes true in terms of the creation of it. But just based on the 52+% social determinants of health being lifted, this is a tremendous opportunity if we can get it right. It is a disruption to the human service sector in particular, but it's also an opportunity for the sector to evolve. And we all have been working towards that in various ways. So I would offer, and I'll put in the chat, your specific comments. We would welcome them at United Way. Jen Cathy had to hop off this call, but she did agree. She's the one. So you can email her. In the summer, Flips and United Way are hosting a series of educational sessions to try to help in that translation. As I said to Carol, we don't say social care. That's not something that is used, that language and terms that we're used to. So there's opportunities for you to engage there. I will share that the feedback so far from our partners, we are advocating to enhance or broaden that term of evidence-based. If you read that, it's requiring evidence-based programs. There are very few of us that are evidence-based, so expanding that. We also want to ensure that we're building off of the great work that's already in place. And that's really systems integration, and many of you are involved in that. Laura Gustin, clearly as the director, a lot of great things are happening locally, and we want to be sure that as CBOs, that you are not getting whiplash or where you have to try one thing, now another thing, and then a third thing. So again, coming together, I want to go back to where Wade brought us at the beginning, which is the strongest effort in this is to come together, to synthesize and organize so that we're able to advocate for the great things that are happening right here locally. So I'm asking for, if you'd like to be engaged, again, we're just helping to communicate and coordinate, and in partnership with many of the partners, please reach out to Jen Cathy, the Human Services Hub. We are also posting information on if you would like to be part of that. And then again, the educational sessions in the summer. Carol, do you want to answer anything specifically to the value-based payment conversation?
Sure.
And I would love for Laura at some point to just share also the work and how maybe the key points of the testimony that she's putting forward.
Yeah, and I think I could thread between the two of you. Yeah, so I agree with everything that Jamie just said. It will be really important for us to kind of stay together as a community and make sure that we are all hearing the same feedback so that we can really kind of lobby and advocate as best as we can. As it relates to VBP, like I said, when I was talking, I do feel that the VBP descriptions in the waiver are quite advanced. And so I believe realistically, what will likely happen is more of a fee schedule model. So something along the lines that's closer to the North Carolina model where, services are identified, a menu of services are identified, interventions that have been kind of promulgated overall kind of at a high level by New York State. To Jamie's point, and I failed to mention this in my presentation, we've had a lot of discussions around this notion of evidence-based, and I want Laura to talk about that because that is a speaking point that Laura brought up that we've incorporated in the high-level talking points about how can you do evidence-based care when you've never had the opportunity to be paid for any care and collect the data and build the infrastructure around it. So we're still in an innovation mode. So it's kind of, it's a concept that's, a little bit doesn't make sense. So Laura can talk about that. So I do think it'll be more simple. A start with the fee schedule with a goal ultimately of moving toward more advanced VBP, baby steps. So Laura, you know, you might want to talk about the evidence-based piece as well as the measurement model for SIP and how we believe that'll be a mechanism for supporting this.
Yeah, I want to pause for 1 minute because I think I would be happy to do that. But Wade, can you, before we jump and change, just speak to the role of the hero in the VBP space? Because I don't want people to think that this is the end. This is like, you know, the stretching before you begin the race.
I absolutely will, Laura, and had planned to do so in my closing remarks. But let me just say, in the spirit of speaking softly and carrying a big stick, I would assure you all that we are digging deep into the proposed role of the hero in the waiver application. And with Dr. Harbin, Common Ground Health's board chair on this call, along with Dr. Apostolaris and Mr. Underwood, I see on the call. If there are other board members, my bosses that I failed to note, please forgive me. But we are very much aware of the fact that this is an opportunity for us to not be so wholly at the fate of what the state bills, because this is really an application that expresses a federated model of distributive leadership. That not only is the state proposing a cookie cutter that gets imposed on everyone, a la its last attempt at the waiver, but it's also not the state looking to say, as Carol noted earlier, we're going to take all the money and give it to one entity in each region. This is multiple funding streams with multiple aims that are in many ways high and contradictory, but the state's document reads that those conflicts get resolved at the regional level by a conversation among stakeholders. And I think the reason why the state calls out Common Ground Health is not because we're excellent, even though my excellent staff is well represented here. They are absolutely muted in their ability to perform by their CEO. I think the state calls out Common Ground Health because of moments like this, my friends, about how it all is that we continue to understand that Fulgham was right, that when it's time to cross the street in traffic, we really do understand that the idea is to look in both ways and to hold hands and to cross it together. And so this is one conversation planned among many. This will not be last. And I think that if we can challenge ourselves to just remember that we don't have to do this alone, we're doing it together, it will become another example of how the Finger Lakes region demonstrates best practice to rest of state.
And then if I could just follow up to Carol's question, I will just say, when systems integration started 4 years ago, part of the intent of that work was to develop the solution without the state dictating what the solution was in preparation for this moment. And because we didn't have the state dictating what the solution was, we ended up asking providers and people in this community what their requirements were to have an integrated system of service delivery. And we have been creating technology and measurement models and workflows and provider networks in preparation, again, for this moment. In some ways, a systems integration project has allowed this region to build and develop the tools and resources for success ahead of where the state is. I do think, to Carol's point, we have been innovating in this space. We always say, whether we're developing a data system, whether we're creating service pathways that don't just pay for a box of food, but actually pay for the connection between providers that move a person from needing a box of food to getting on public assistance, to having access to an available place to purchase food outside of their food desert, and how do all of those things create food stability? You know, those are the types of conversations we're having at the SIP table. And so, in part of our conversation with New York State, first, we're really asking for the space to continue to be innovators. And when you're an innovator, you are building beyond the evidence base. And we don't want to be limited by the evidence base, but we want to be given the guardrails to innovate, to meet the state's goals based on the work that we've done and to build upon the work that we've done. A couple of other things I'll highlight just to Jeff's point, one of the key things we've done in systems integration is include the education sector in our work. Carol noted social determinants of health and education are the same. Schools, school leadership, teachers, school social workers are trying to address social determinants of health in the exact same way that healthcare providers would like to address them. And we've learned through the work of systems integration project that people want a single approach. And so we need amongst ourselves to have an integrated approach to service delivery to meet those needs. So I would say we're well positioned. We have built amazing relationships through COVID that have shown how productive we can be in the face of big asks. And I think we're really excited to expand the tools of SIP throughout others in this community and through the region. We're excited to answer any questions. And the final thing I'll say, our measurement model was really designed to create new business intelligence. So providers, whether it's a CBO, whether it's a school, whether it's a doctor, could determine their value within an integrated system. And so Carol talks about begin pulling your data. And many of you might find, I don't got the data to tell this story, but just know we have spent the last 3 years figuring out how to do that. Those systems are currently being deployed. We are in early adoption, but are really excited to expand that to anyone who desires as we really prepare for regional success in this space.
Thank you, Laura. So in the interest of respecting the 165 people that have stuck it out with us for this call, there are some other great questions in the chat, but we haven't had a chance to get to them yet. I'll encourage everyone as I hand it back to Wade to wrap up. If you do have questions that you haven't had a chance to ask yet, please do drop them in the chat. As I said, we're going to work on an FAQ. And try to respond to everything that we can as we follow up on this conversation. With that in mind, I'm going to hand it back to Wade to just walk us quickly through timeline and next steps. Let me pull your slides up, Wade.
And with that, I never want to interrupt Wade, but Karen Zandy, to her true form, asked a really great question around responding as a community. And I hope, Wade, you'll address that. It's a great way.
I saw it as well, Jamie. Thank you for making sure that I did not miss it. Let me thank Jamie and Laura and Carol and so many of you who have helped us make it safely on the journey to this point. And let me thank all of you for being here and being a part of today's conversation. And those of you who know me know that as Pastor Norwood, I am incredibly practiced in pronouncing the moments that are speak now or forever hold your peace. Let me say to you that this is not such a moment. I hope that you will continue to keep speaking, and that as additional thoughts and information comes along, you will continue to share questions, comments, or concerns with us. And we will work to, as Albert said, widely share those concerns among all of us, so that we're all continuing to move forward with a shared understanding. With regard to responding to the state with comments that are relevant to the waiver application, the state government, I can assure you, just in the 4 meetings I've had this week with high-ranking state officials, The state government is especially looking to our community for guidance and support in the evolution of this draft application. To comment to the state, you all should have the link. I believe it was dropped into the chat for sending in written comment and for offering verbal testimony to provide comment to us for our regional understanding. Albert has just put into the chat the link for the survey for the report. And because of the fact that we are all friends and we all not only know each other's cell numbers, but in too many cases for discomfort, we know each other's children's names and we know each other's spouses. Zip an email, make a phone call, send a text. That's what's going to help us continue to use this as an opportunity for us to not only strengthen the draft application, but also strengthen our own work. And let me assert that what we have is simply that. It is a draft application. This application is going to be amended based on the public comment that the state receives. So please share your comments and dare to dream and be bodacious enough to challenge the state and the federal government to act on your dream and our vision as well. Rest assured, I've been saying in both written and verbal communications with the state on behalf of Common Ground Health and on behalf of our statewide affiliations that we are concerned about how weak this document is with regard to babies, children, and their families. As a regent of the state of New York, I cannot help but be hurt and disappointed that schools are left out. The unique needs of rural communities and a waiver that is focused on equity are not surfaced in this document. And the social determinants of health network construction is still, to me, as a mouth-breathing West Sider in this county, it's still very unclear. But my friends, let me close by saying the final application is not going to be the waiver program. We won't know that until the federal government approves a program, and that won't happen until late in this calendar year. As you can see by Albert's slide timeline, we're just laying out the first 2 calendar quarters of where things happen. I'm guessing it's going to be late calendar Q3 or Q4 before we actually hear from the federal government. The comment period, as we have said, has been declared as a 30-day window with opportunities for verbal testimony that as of yesterday changed to be May 3rd and May 10th, and with written responses due on May 13th. We have broadly distributed links for both of these opportunities, but if you know of somebody who doesn't feel they've been informed, would you please share the information with them and tell them you are a part of the community of leadership of this and you're sharing it with them. They don't need to wait till they get an email from me when you can share it along, but please invite people to be involved. I'm going to take 2 more minutes and let you go. After this comment period, DOH is going to review the feedback, finalize the submission of a formal waiver application to CMS, which will then review and determine whether to approve the state's application, amend it, or deny it. We, and this is the royal we of Common Ground Health, all of our partners and all of so many of you on this call. We have been collaborating with numerous stakeholders to organize this feedback survey and encourage you once again to help us disseminate and get responses back. And I'll confess to you, my friends, I don't expect the state to make its final application and federal agreement do all that we want. I'm a cynic. I've been around for far too long. But what I do expect is that the state will partner with us to make sure that its final agreement doesn't stand in the way of what we know needs to happen in order to improve life in our community. And that means that our real task, as I've hinted earlier, is not to view this waiver as an end, but rather as a means to an end, a pathway to the day where all of these things that we know support health and wellness are simply paid for by the health insurance dollar as a matter of course. That these things exist in our community, in community-based organizations that will not be dependent on addressing the social determinants of health, on a Hunger Games that competitive grant making often creates, but rather invested in as simply the way in which we will reach the triple aim faster and more equitably than otherwise. It's not going to be easy. Douglas was and is still correct. Power is not wrested away without a struggle. But that's why we're in this liminal space, to get ready for the struggle. Ours is the job to use this window of time and the unique resources of the American Rescue Plan to engage in that struggle, to have the courageous conversations that are necessary, to get into good trouble by creating necessary trouble. And as we do so, let me remind you of the wisdom of Sister Toni Morrison. She said that as we enter into positions of trust and power, that as we marshal facts that prove our point, that we should never fail to invite each other to first do a little dreaming and do a little loving before we act and think. God bless you all. Thank you for being with us and have a wonderful weekend.